Coding Corner Medical Coding Education. My name is Rebecca Broyles, and I want to talk about Beyond the Base Units, elevating your anesthesia coding skills. We're going to walk through the essential components of anesthesia coding, including ASA classifications, time reporting, common modifiers, and real-world case examples. This is designed to strengthen accuracy, reduce denials, and improve compliance. By the end of this presentation, you should feel confident selecting anesthesia codes, assigning ASA status codes, and calculating time. We'll also review case examples to reinforce these concepts. An overview of anesthesia coding. Anesthesia coding differs from surgical coding because it focuses on the anatomic region rather than the specific surgical technique. Reimbursement is calculated using a formula that includes base units, time units, and applicable modifiers. Anesthesia includes general anesthesia, which brings on a sleep-like state with the use of a combination of medicines. Monitored anesthesia care, or MAC, it's often called the conscious sedation or twilight sleep. It's a specialized service where an anesthesia provider administers sedatives and pain medication to keep a patient comfortable, relaxed, and sleepy, yet conscious or easily rousable during procedures. And then regional anesthesia. This is a type of pain management that numbs a specific large area of the body, such as an arm, leg, or the lower body, by injecting anesthetics near the nerves. ASA modifiers reflect patient complexity and risk. They are required by many payers and can affect reimbursement. Documentation must clearly support the assigned ASA level. Here you will see the ASA physical status modifiers. P1 is a healthy patient. P2 is a mild systemic disease for the patient. P3 is if a patient has a severe systemic disease. P4 is a severe disease, constant threat to life. P5 is moribund, not expected to survive without the surgery. And P6 is a brain-dead organ donor patient. A systemic disease is a medical condition that affects the entire body rather than a single localized organ or body part. These diseases, such as diabetes, lupus, or influenza, often involve multiple organs and tissues simultaneously. They frequently require complex, long-term management and can cause widespread symptoms like fatigue and fever. Accurate time reporting is critical. Time starts when the provider begins continuous attendance and ends when the patient is safely handed off. Always check payer rules for rounding. You will see here on this slide, the time begins when the anesthesia provider begins preparing the patient, and it ends when the patient is safely placed under post-operative care. It is reported in minutes, and time units typically calculate in 15-minute increments. Modifiers identify who provided the anesthesia service and under what circumstances. They directly impact reimbursement. MAC cases require documentation of medical necessity. Some common anesthesia modifiers are AA, which is the anesthesia was personally performed by the anesthesiologist. QK, medical direction of 2 to 4 concurrent cases. QY, medical direction of 1 CRNA. QX, CRNA service with medical direction. QZ, CRNA service without medical direction. And QS, monitored anesthesia care, or MAC. All of these should be documented. MAC is not simply sedation. It requires the presence of an anesthesia professional capable of converting to general anesthesia if needed. Again, documentation must justify why the MAC was required. Documentation must support every coding element. Missing or unclear documentation is a common cause of denials. Some requirements are the pre-anesthesia evaluation, intraoperative monitoring, the anesthesia start and stop times, the post-anesthesia evaluation, medical necessity for MAC, and the ASA physical status justification. Some common coding errors in anesthesia are, again, the incorrect ASA status modifiers, missing MAC documentation, incorrect time reporting, wrong anatomic site code, and missing modifiers. These errors can lead to claim denials or underpayment. Regular audits help maintain compliance. Some case examples. This is a colonoscopy with MAC anesthesia type. The ASA of the patient is a P2, and the time spent was 45 minutes. We have the CPT code of 00812, which is the anesthesia code performed on lower GI endoscopic procedures. The modifier QS is for MAC procedures, and the ASA modifier P2 would be added. This is a straightforward MAC case. Here we have total knee arthroplasty. The total knee arthroplasty falls under the knee joint anesthesia code. Again, we have the anesthesia as general. The ASA code is P3, which means the patient has severe systemic disease, and the time reported is 2 hours or 120 minutes. Therefore, the CPT code would be 01402 for the knee joint surgery with a modifier AA showing the anesthesiologist personally performed and an ASA modifier of P3. This is an emergency appendectomy. Now, emergency procedures require the ET modifier for emergency. They have general anesthesia. The ASA is P4. The patient's condition places them at high risk, thus supporting the P4. The time is reported as 90 minutes. The CPT code would be 00840, anesthesia for the lower abdomen, modifier ET for emergency, and the ASA modifier P4. Anesthesia coding is based on anatomic site. ASA modifiers reflect patient risk. Time reporting must be precise. Modifiers are used to identify the provider role. Case examples reinforce correct application. Accurate anesthesia coding requires attention to detail and strong documentation. Applying these principles consistently improves compliance and reimbursement. Thanks for joining us and for watching. Visit us at www.thecodingcornermce.com.